Okay, welcome to the deep dive. We're diving deep into your source material today, taking a stack of notes and really pulling out the absolutely crucial insights.
Yeah, the stuff that helps you get informed fast or maybe, nail that revision.
Exactly. Think of us as guides, helping you navigate through maybe some dense information.
That's right. We're here to help you see the key points, understand the landscape, and walk away with the most important knowledge nuggets about a specific topic.
And today we are tackling something incredibly common, particularly in childhood. Based on the notes you've shared, we're doing a deep dive specifically into glue ear.
Which is also known more formally as otitis media with effusion, or OME.
Right. So our mission here is to turn these detailed revision notes into a really clear, high-yield understanding of glue ear for you listening.
We'll cover everything, from what it actually is, why it happens, through to diagnosis and management.
Highlighting the key facts, building that solid, memorable picture.
Exactly.
Let's unpack this then. Ready to jump in?
Absolutely. Let's do it.
Okay, so let's start right at the beginning. Glue ear. What exactly is happening inside the ear when we talk about this?
So at its core, glue ear is basically fluid collecting in the middle ear space. That's that little, normally air-filled cavity just behind the eardrum.
And glue ear because...
Well, the name's pretty descriptive, actually. This fluid can often get quite thick and sticky, almost glue-like, not just watery.
Got it. So it's not necessarily like an active infection brewing in there.
Not usually, no. It's more about the fluid just sitting there when it shouldn't be, though it often follows an infection.
Okay. And the main problem this causes is?
Hearing loss. That fluid stops the eardrum and those tiny little bones behind it from vibrating properly when sound waves hit.
Right, so it muffles the sound. Like putting cotton wool in your ears, maybe?
That's a good way to think about it, yeah.
Yeah.
And this leads directly to temporary hearing loss.
Okay. And who mainly gets this? The notes seem very focused on children.
Overwhelmingly, yes. It's primarily a condition of childhood. Adults can get it, but it's much, much more common in kids.
Why is that?
It's mainly down to their Eustachian tubes. Those are the little passages connecting the middle ear to the back of the throat. They're meant to drain fluid and equalize pressure.
Ah, okay.
In children, these tubes are, well, they're narrower, they're more horizontal, and frankly, just less efficient at draining fluid compared to adults.
So the plumbing isn't quite as good yet, basically.
You could say that, yeah. The drainage system isn't fully developed.
And the notes really stress this point. Even though it's often temporary, this isn't a minor thing. It's stated as the most common cause of hearing impairment in children.
It absolutely is. That's a really crucial fact to remember. And while, a lot of cases do clear up by themselves, they spontaneously resolve if it hangs around or causes significant hearing issues.
Then you need to do something.
Then intervention might be needed, sometimes even surgery, like putting in grommets, those tiny tubes, or maybe removing the adenoids if they're part of the problem.
And the hearing loss itself isn't trivial. The notes mention a range, 20 to 50 decibels?
That's right, 2050 dB, which is, quite significant. It can make it hard to hear clearly, especially in noisy environments like a classroom.
Definitely. Imagine trying to learn language with that kind of dampening effect. Okay, maybe an analogy could help here. Like, the middle ear is a small room.
Yeah.
And the Eustachian tube is the drain. Glue ear happens when that drain gets blocked and the room fills up with sticky stuff instead of staying airy.
That's a great way to visualize it. It really is all about that block drainage.
Okay, so that leads us to the next obvious question. Why does that drain get blocked? What are the causes, the etiology of glue ear?
Well, the number one culprit, the main mechanism, is that Eustachian tube dysfunction we mentioned. If the tube isn't opening and closing properly, fluid can't get out and air can't get in to equalize the pressure.
Right. And what makes the tube dysfunctional? What contributes to this fluid building up? The notes list several things.
Yeah, basically things that can cause inflammation or physical blockage around the opening of the Eustachian tube at the back of the nose.
Such as?
Things like recurrent ear infections, acute otitis media are a big one. Allergies, too. Enlarged adenoids, which is called adenoid hypertrophy, they sit right near the tube opening, so if they're big, they can block it.
Okay, location, location, location.
Exactly. Also, certain genetic factors and conditions like cleft palate, which affects the anatomy of that whole area.
Okay, quite a mix. Maybe a little memory aid for those associated factors.
Right.
Things that block or irritate near the tube. How about area AG? A for allergies.
R for recurrent infections.
B for enlarged adenoids.
A for anatomical issues, like cleft palate.
And G for genetic factors, area G.
Area G. Yeah, that covers the main ones nicely.
Okay. Now, let's dig into the risk factors a bit more. The notes make a really clear split here between kids and adults.
They do, and it's important. The list for kids is pretty long, reflecting how common it is.
What are some key ones for children?
Well, age is a big one. The peak is around 2 to 5 years, but it's very common younger than that, too. Exposure to tobacco smoke is a major risk factor.
Even passive smoking.
Absolutely, even passive smoke. Having a family history of ear problems, getting frequent colds or upper respiratory infections, and attending daycare, just more exposure to bugs, really.
Makes sense. More colds, more congestion, more chance of the tube getting blocked.
Precisely. Then there are other factors, like being male boys get it slightly more often, higher rates in winter and spring, which ties in with cold season. Bottle feeding is mentioned as a risk compared to breastfeeding.
Interesting.
And then specific conditions like Down syndrome and cleft palate, where the risk is much higher. Even having older siblings, lower socioeconomic group, and possibly links to things like reflux are mentioned in the notes.
Wow. Okay. So environment, genetics, anatomy, common childhood illnesses. It really shows how many things can lead to glue ear in a child. Now, let's contrast that with adults.
Yeah, and this is where there's a really critical point highlighted in the notes. Adults can get OME, maybe from Eustachian tube dysfunction after an infection or inflammation, or maybe barotrauma from flying.
Right.
But the absolute key takeaway for adults is unilateral fluid.
Just in one ear. Why is that so important?
Because finding fluid only in one middle ear in an adult is a potential red flag. It needs thorough investigation because it could signal something serious, blocking the Eustachian tube from the outside, like a nasopharyngeal mass or tumor.
Oh, right. That's serious.
Very. Acute ear infections are actually quite rare in adults compared to kids. So persistent fluid on just one side is much more worrying for an underlying structural cause in an adult. Other adult risk factors listed are things like previous radiation treatment to the head and neck, major surgery in that area, and chronic allergies.
Okay, that's a massive point to remember. Kids, one ear, both ears, often temporary. Adults, one ear. Think serious possibilities until ruled out.
That contrast is absolutely vital. Definitely a key clinical pearl from these notes.
Got it. Let's briefly touch on the pathophysiology, sort of. How does it actually happen step by step?
Well, the notes basically describe it as that mix of the Eustachian tube not working right plus inflammation. That combination leads to the fluid starting to build up.
And then it gets sticky over time.
Exactly. That fluid can then thicken, becoming more glue-like, making it even harder to drain.
And the notes put OME in context with other ear problems, right? A spectrum of otitis media.
Yeah, they list things like acute otitis media, AOM, which is the active infection, OME itself, chronic suppurative otitis media, CSOM, often with a perforated eardrum, mascoiditis, and cholesteatoma.
So OME is part of that family of conditions.
Right, and it's specifically defined as chronic inflammation without the acute signs you see in AOM, like severe pain or fever. It often follows an episode of AOM. The infection clears, but the fluid stays behind.
Ah, the infection's gone but leaves its mark. Understood. Now, hearing loss is the main symptom, but lots of things cause hearing loss. So differential diagnosis, what else might it be?
Yeah, super important because the treatments are different. You need to consider other possibilities. The notes list the main ones.
Which are?
Acute otitis media isn't actually an active infection right now. Chronic otitis media, usually meaning CSOM, a long-term issue, often with discharge. Sensorineural hearing loss is the problem with the nerve, not the middle ear fluid. And structural ear abnormalities because there's something physically different about the ear structure.
Okay, so basically, is it infection? Is it nerve damage? Is it a physical abnormality? Maybe a quick mnemonic. How about SCS? S for sensorineural.
A for acute OM.
C for chronic OM.
S for structural abnormality, SCS.
SCS.
Yeah.
Works for me. Okay, let's talk numbers. Epidemiology. Just how common is this?
The figures are pretty staggering, actually. The notes say something like 80% of children will have had at least one episode of glue ear by the time they're 10 years old.
80%, wow.
Yeah, and more than half get it in their first year of life. The peak age is really young, sort of 6 months to 4 years old.
That's almost universal in early childhood then.
Pretty much. It affects about 1 in 8 primary school children at any given time. And the rates are way higher, like 60, 85% in kids with Down syndrome or cleft palate.
Which links back to those anatomical risk factors.
Exactly. And again, it's confirmed as the #1 cause of childhood hearing loss. Less common in adults, maybe slightly more in boys, peaks in winter. But that 80% by age 10 figure, that really tells the story.
It really does. So if it's that common, what are we actually looking for? How does it present clinically?
Well, the notes say symptoms can vary, but yeah, the main one is hearing loss. In kids, this often gets noticed around age 2, maybe a bit earlier or later.
And how might that hearing loss show up?
It could be subtle. The notes give examples like mishearing things, asking for the TV to be turned up louder, maybe having difficulties with communication, or seeming like they're not paying attention.
Right, the selective hearing might actually be real hearing loss.
It might. Beyond just hearing, parents might notice things like lack of concentration, seeming withdrawn, maybe delays or issues with speech and language development, or even problems with school progress. Occasionally, there might be a mild earache or tinnitus, sometimes balance problems too.
So it can really affect quite a few areas: behavior, learning, development. If we wanted a quick reminder of key child symptoms, maybe think about the impact areas. H for hearing,
S for speech language,
S for school concentration.
B for balance,
Yeah.
HSSB.
HSSB. I like it. Now, what about what a doctor sees when they look in the ear with an otoscope?
Okay, signs on examination. The notes detail specific things to look for. The eardrum, the tympanic membrane might look dull or opaque, cloudy, instead of clear and pearly gray.
Not see-through anymore.
Exactly. And crucially, there shouldn't be signs of acute inflammation like redness or pus that's key for distinguishing OME from AOM. The drum might look retracted, pulled inwards, or its movement might be decreased when the doctor uses a little puff of air.
The pneumatic otoscopy part.
Right, and sometimes you can actually see the fluid level or even air bubbles behind the drum. It might have a yellowish or amber color. The notes do mention that bulging of the eardrum is less typical for OME compared to acute infection.
So specific visual clues. And for adults. Remind us again.
Adults, symptoms often unilateral, remember. Hearing loss, that feeling of fullness or pressure, oral fullness, maybe crackling or popping sounds, tinnitus, sometimes feeling like there's something in the ear, rarely mild pain, maybe some vague unsteadiness.
Okay, clear differences there. So you suspect glue ear based on the story and the look of the eardrum. How do you confirm it? Investigations.
Well, the notes are clear that the diagnosis is primarily clinical. It's based on that assessment, the history from the patient or parents, and the otoscopy findings we just talked about.
But there are tests to back it up or measure the impact.
Yes, definitely. Tympanometry is a really key investigation. It uses sound and air pressure to check how well the eardrum is moving, which gives a good indication if there's fluid behind it. The notes even give its accuracy pretty good sensitivity and specificity.
Okay, so that checks the mechanics.
Then there's audiometry, the formal hearing test. This measures the actual degree of hearing loss, and obviously you use age-appropriate tests depending on how old the child is.
So otoscopy to look, tympanometry to check movement, audiometry to measure hearing. Makes sense. And the notes mention regular checks for high-risk kids.
Yes, regular assessments are recommended for children with conditions like cleft palate and Down syndrome, given their high risk.
And what about referral and just waiting?
Yeah, that's a big part of the pathway. If it's persistent, referral for formal hearing tests or to an ENT specialist is standard. But the notes strongly emphasize that initial period of active observation or watchful waiting, often for about 3 months.
Because it so often gets better on its own.
Exactly. Why jump to intervention if it might resolve? The typical hearing test finding, by the way, is a mild conductive hearing loss. The sound conduction through the outer and middle ear is impaired by the fluid.
Right. And just to hammer it home, that adult point again.
Absolutely crucial, so worth repeating. Adults with unilateral OME fluid in just one ear must have a thorough evaluation to rule out underlying causes like sinus issues or, importantly, tumors in the nasopharynx. That might involve looking up the nose with a camera, maybe even a biopsy.
That unilateral adult rule is definitely sticking. Okay, so clinical exam, key tests like tympanometry and audiometry, watchful waiting, and that critical check for adults.
That sums up the investigation pathway well.
Right, so we have a diagnosis. What do we do about it? Management.
Okay, management. The notes lay this out quite logically. First, acknowledging spontaneous resolution and observation. Then, non-prescribing techniques. Then, surgical options for persistent cases. And finally, pharmacological treatments, or rather, the lack of them.
Start with the most common route, just waiting.
Pretty much. That active observation for up to 3 months is the first step for most, because, as we keep saying, spontaneous resolution is really common.
Okay, but if it's not getting better, or while you're waiting, what non-drug approaches are there?
The notes mention autoinflation using a special nasal balloon. This is for children who are old enough to cooperate, usually maybe 3 or 4 years and up.
How does that work?
The child basically inflates this balloon device, using their nose, one nostril at a time. It gently forces air up the Eustachian tube, helping to open it and encourage the fluid to drain. It's like manually trying to pop your ears.
Clever. Any other non-drug options?
Hearing aids are mentioned. They can be a good option for children with persistent bilateral OME causing significant hearing loss, especially if surgery isn't wanted or isn't suitable for some reason. They just amplify the sound to overcome the blockage.
Okay, so trying to help drainage or just boosting the volume. What about when surgery is on the table?
Surgery is generally reserved for cases of persistent bilateral OME so fluid in both ears that it hasn't cleared after that observation period, usually 3 months, and is causing significant hearing loss.
And the main surgery is?
Grommet insertion. It's listed as the first-line surgical treatment. A tiny ventilation tube, the grommet, is inserted through a small cut in the eardrum. That's the myrigotomy part.
And the grommet's job?
It basically acts like an artificial Eustachian tube. It lets air get into the middle ear space, equalizing the pressure and allowing any fluid to drain or be absorbed. The notes say they typically stay in place for about 10 months before falling out on their own.
So it's like putting in a tiny ventilation shaft.
Exactly. Another surgical option mentioned is adenoidectomy, removing the adenoids. This is usually considered if the adenoids are enlarged and thought to be blocking the Eustachian tubes, or if the child also has problems like recurrent tonsillitis or nasal blockage. Sometimes it's done at the same time as grommets.
Okay. The notes had a point about grommets and speech development.
Ah, yes, an important nuance. While grommets definitely improve hearing, the notes mention that studies show they have limited impact on improving language and speech development outcomes themselves. Hearing improves, but the link to accelerating speech isn't as strong as perhaps once thought. Laser myridotomy is also mentioned as quick, but the hole might close up faster.
Interesting. So grommets are mainly for restoring hearing function. Now, the big one, medications. What pills or sprays fix glue ear?
This is probably one of the most important management points from the notes. There is any way effective medication for the glue ear fluid itself. None.
Really? No decongestants or anything?
Nope. You can use simple pain relief like paracetamol or ibuprofen if there happens to be some associated earache, but that's rare with just OME. And antibiotics are only for treating a definite coexisting bacterial infection like acute otitis media, not for the fluid alone.
That's crystal clear. Meds don't clear the fluid. And the notes specifically say what not to use.
Yes, they explicitly state to avoid antihistamines, decongestants, and both oral and topical nasal steroids for treating glue ear. There's no good evidence they help drain the middle ear fluid, and they can have light effects.
Good to know what doesn't work. What about speech therapy?
That is mentioned, yes. For children considered at risk of speech and language delay because of chronic glue ear and hearing loss, speech therapy referral makes sense to provide targeted support.
Okay, so summarize the management path. Watch and rate first. Maybe try autoinflation or hearing aids. If it's persistent and causing hearing loss in both ears, consider surgery, usually grommets, maybe adenoidectomy. And crucially, avoid ineffective medications like decongestants or steroids for the fluid itself.
That's a very good summary of the pathway outlined in the notes.
Great. So what's the typical long-term picture? Prognosis.
Overall, it's generally good. As we've stressed, most cases resolve spontaneously, usually within a few months, sometimes up to a year.
Does anything make it more likely to stick around?
Yeah, it's more likely to be persistent if there are multiple contributing factors like allergies plus big adenoids plus recurrent infections. The notes also mention that older children might have a slightly better chance of it resolving on its own compared to very young infants. And an interesting point, adults who get OME often had issues with it when they were kids.
So usually gets better but can be stubborn sometimes. Okay, last section. What can go wrong? Complications.
Well, the most direct complication is the hearing loss itself, which can be persistent if the OME doesn't resolve. This, in turn, can potentially lead to speech and language delays and educational difficulties, particularly during those key early learning years.
But the notes qualified the speech link.
Yes, they mentioned it's generally considered a weak association and often temporary once the hearing is restored. So potential, but maybe not as direct or permanent as sometimes feared.
Okay, what else?
The notes mention that some studies suggest a possible link between chronic OME and things like anxiety, depression, or attention deficit disorders in children, but it's framed cautiously, not as a definite cause and effect.
Right, association, not causation necessarily.
Exactly. Also, long-term chronic glue ear can lead to structural changes in the middle ear, things like thinning or retraction of the eardrum.
Damage from the persistent fluid or pressure changes?
Yeah, essentially. And then there are rarer complications listed, like a perforation, a hole developing in the eardrum, or the formation of something called a cholesteatoma.
What's that?
It's basically an abnormal skin growth that can form in the middle ear space, and it can be quite destructive if left untreated. It's rare after OME, but it is a potential long-term complication.
Okay, so mostly hearing and developmental impacts, but some potential structural issues and rarer serious things to be aware of. Any notes on prevention?
Very limited in the source material. Just one specific mention that the AH1N1 flu vaccine was potentially linked with preventing some cases. But interestingly, the pneumococcal vaccine, PCV, was specifically noted as not preventing OME.
Okay, interesting, but perhaps not widely applicable prevention strategies from these notes. But knowing the complications is important for monitoring.
Absolutely. It helps guide follow-up and decisions about intervention.
Right. That feels like a really thorough journey through these revision notes. We've covered the definition of glue ear, its causes, the risk factors, really highlighting that crucial kid versus adult distinction. We looked at how it develops, what else it might be confused with, the sheer number of kids affected, how it looks clinically, how it's investigated, the whole management pathway from waiting to surgery, the usually good prognosis, and those potential complications, all drawn straight from the source material you provided.
Yeah, I think the main takeaway is just how incredibly common this is in childhood, causing that temporary hearing loss. And while it often gets better by itself, persistent cases definitely need attention because of the potential impact on hearing, possibly development, and those rarer complications. Knowing the signs, knowing when to wait, and knowing when to act or refer is key.
Absolutely. So here's a final thought for you, the listener, to maybe mull over. Given that glue ear is so common and often temporary, yet it can significantly impact hearing and learning during really crucial developmental windows. How does that reality shape the balance between watchful waiting and deciding when intervention is truly necessary, especially in very young children?
And linked to that, reflect on why that same finding fluid in the middle ear prompts such a different, more urgent line of thinking when it's unilateral in an adult compared to a child. What does that tell us about clinical reasoning?
Great points to ponder. Well, thank you for joining us on this deep dive.
Yes, thank you for listening.
And if you are looking for more resources like this, turning complex notes into clear, high-yield knowledge, particularly for medical exams, you can find valuable material over at passthemsra.com.
And also at freemsra.com.
Until the next deep dive.
See you then.